Thank you very much. I'm going to talk about congenital disorders of glycosylation, and as you can see here from the first picture already, these are very severe multisystemic disorders. It's a 6-month-old girl. You can see that she has no hair anymore, and she has severe inflammation and ichthyosis of the skin. And that's a video of her when she was 6 months old. And what you realize is that she has a very severe muscular hypotonia. She's not able to grab the toy. She's not able to turn herself around, which she should be able to at this age. Right. So, congenital disorders of glycosylation normally are very severe multisystemic disorders, and this talk is going to focus on treatment options. I'm going to focus on N-glycosylation. As you realize, there are other types of glycosylation as well, and you can see just by focusing on that, it's a very complex process. In this yellow, in this bright green, you have the endoplasmic reticulum, and you have the Golgi apparatus down here. And you can see that the N-glycans are subsequently assembled sugar by sugar on a lipid molecule in the endoplasmic reticulum membrane. And when they are completely assembled, then they are transferred to the nascent chain, to the newly generated protein. And then they are processed in a complex manner until they are finally released to the destination. So, concerning the nomenclature, we call CDG1 disorders the ones that affect the assembly of the glycan in the endoplasmic reticulum, and CDG2 disorders that affect the processing. There's a simple test in order to screen for these patients, and that is if you look at the serum glycoprotein and the N-glycosylation of it, and it has been, transferrin has been the most commonly used. Transferrin has 2 N-glycans attached to it. And there are several sugars in it. The terminal ones are the negatively charged sialic acids. The other ones are uncharged. So if you have a structural defect in this glycan, or you have a missing glycan, you always lose 2 or maybe 1 sialic acid, and you have a difference in the charge. And that you can use for a test. You can do an isoelectric focusing of the transferrin. That's how it looks like normally when you have the 2 glycans attached. And if you have a CDG1 disorder, where you have a problem with the assembly of the glycan, then 1 or 2 of the glycans are missing, and you lose 2 negative charges from the sialic acids, and you have, instead of tetrasilotransferrin, disilotransferrin, or asilotransferrin. That is due to the fact that the oligosaccharotransferase looks for the completed glycan, and if the completed glycan is not there, it will not transfer it to the protein. So all these CDG1 disorders have the same phenotype in the isoelectric focusing pattern. So with HUD, I have a long-standing collaboration that goes now more than 10 years ago, and there was the first patient we encountered together, and it turned out he had a glycosylation disorder which can be very well treated. And it was a very exciting time, and when that was finished, we thought, that it's a once-in-a-lifetime event, but then the second patient with a different disorder came along with a similar story. So the first disorder was CDG1B, and that was a boy who was severely ill when he was 6 years of age. Due to thrombosis he had the year before. He was treated with an anticoagulative treatment. And as a consequence, he got very severe gastrointestinal bleedings. He received an incredible amount of blood transfusions, and gastrointestinal arteries were surgically interrupted, but the bleeding could not be stopped. And it turned out to be a positive CDG test in this child, and it was not understood in the beginning what was the reason for that. But it turned out that the metabolic problem is in the pathway at this place. Just very early in the beginning of the assembly of the glycan, you see that the N-acetyl-glucosamine is put on, the second one here, and then you need many mannoses that have to be attached to the glycan. And the mannose metabolism in the cytoplasm is depicted here. And mannose 6-phosphate is converted to mannose 1-phosphate and then to GDP mannose, and that is needed to include the mannose into the glycan, to incorporate the mannose into the glycan. And the problem here is in this phosphomannose isomerase that converts fructose 6-phosphate to mannose 6-phosphate. So if you have a problem here, if this gene is not working, then you cannot generate mannose endogenously anymore for incorporation into glycans. So the way around was to increase the dietary amount of mannose, to give mannose orally in order to phosphorylate it directly to mannose 6-phosphate and thereby to circumvent this metabolic block. And this worked very nicely. As you can see here, this is an SDS page of the transferrin where you can see this normally glycosylated transferrin, the transferrin missing 1 glycan and 2 glycans. And if with prolonged times of treatment, here you see the boy taking the daily mannose dose, you can see that glycosylation is completely restored. And there was a considerable clinical improvement as well. So when I talked about this at a scientific meeting, Professor Bickel was there. He was a pioneer of the treatment of metabolic disorders. He developed the therapy for phenylketonuria in 1952. And when I gave a talk, I walked up to him and said, you know, not all the things have to taste as bad as your amino acid supplements. And I gave him a little of the mannose here. And I expected him, you know, just to take a small drip of it, but he basically drank all of it. And I was very happy to see him next morning alive and well, because there are toxic effects of mannose as well. So the next patient we encountered was this boy, who, when I took the video, was 18 months of age. And you see that there are several things you can note. The extremities are very short. He has a broad nose, and with 18 months of age, he is has a severe motor delay. He can turn around, at least with a little help. He cannot sit by himself. So things he should do with 5-6 months of age, he cannot do then. But the major feature was he had a lot of infections, and when we plotted the neutrophil counts or the leukocyte counts and the neutrophil counts over his first year of life, you could see that they were severely elevated. And the reason for that was that there was a sugar missing at the surface of the neutrophils, and the sugar is called Lewis X or silyl Lewis X. And what was missing in this structure was the fucose. And because silyl Lewis X is needed for attachment of the neutrophils to the endothelial membrane in order to transmigrate into the tissue, that would not work. And they had a lot of leukocytes in the blood, but none in the tissues. And it turned out that the problem was a defect in the GDP fucose transporter that would import the GDP fucose into the Golgi apparatus so that it could be used there for fucosylation. And here again, we started to try a sugar therapy. Here you see the leukocyte counts before therapy was initiated. And then with very carefully, with very small amounts of fucose supplementation in his diet, you can see that immediately the leukocyte adhesion defect is restored. The leukocytes went down to normal. And after about a year in the hospital, the patient could be discharged after a short while. So that was nice, but frustrating was the work on CDG1A. CDG1A is the most frequent congenital disorder with more than 1,000 patients known. And it's very easy to recognize, especially in the infant period. They all have internal strabism. They have inverted nipples, and they have abnormal supragluteal fat pads. If you see this on a baby, it's pretty sure that it is CDG1A. It's a very severe disorder. About every 5th child will die in the first 2 years of life from various problems. You can see some of them here. This baby has ascites. She has hypertrophic cardiomyopathy. She has perfusion problems in the heart, very severe and life-threatening disorder. And if you survive it, you will not learn to walk normally, and there will be a lot of clinical problems that will continue to be there. So the problem here is in the phosphomonomutase. It's one step further down the road, but here you cannot use mannose therapy actually, because the mannose will go in here, and that's before the metabolic block occurs. But Hart had shown years ago that if you add mannose to the culture medium of CDG1A fibroblasts, it will correct the metabolic defect within seconds. And we still don't know why that is. So quite a few people tried to give mannose then to children with CDG1A, and that was actually pretty frustrating. And in order to show you how we followed that, biochemically, I will just show you once more the CDG test. You can also quantify these hyposialylated isoforms of transferrin by an HPLC method. And if you do that and follow that with time and look for treatment response, you can look at the tetrasialotransferrin, you can look at the hyposialylated isoforms, and if you have no treatment effect, it will look like this over time. And if you have a treatment effect, the tetrasialotransferrin will go up, and the hyposialylated transferrin will go down. So when mannose was tried in children, it looked like this. If you treated them for a year or longer with 1 gram per kilogram body weight, nothing would happen. It was a very constant situation. And part of the reason is that the mannose concentrations you reach in the serum of the children are not as high as the ones you need in the cell culture to correct the defect. So then from Mark Lehrman's group in Dallas, 2 papers were released in order to look at the mannose effect on CDG1A fibroblasts. And the first paper dealt with metformin, an anti-diabetic drug, which will increase the uptake of mannose into the cells. And what it could show is if you add smaller amounts of mannose in HUD experiments, you need 250 micromolar or more. If you use smaller amounts of mannose, you get a correction if you add metformin instead of no correction if you don't do it. And the second paper from the same group a few years later had another interesting concept, and there was a concept called translational balancing. And that meant, normally you have enough sugars to glycosylate your protein. If you cannot make enough sugars for your protein, then you have hypoglycosylation. But then if you turn down translation again, the remaining pool of the sugars might be sufficient to glycosylate the amount of proteins you have. So actually we tried both concepts in 2 children for several years now. So I first show you the treatment with a drug that is suppressing protein synthesis, following this translational balancing concept. And here you can see different isoforms of the transferrin measured with time, but these are the ones that are not affected with CDG1A. The one that is affected is a disilotransferrin, and you can see that the disilotransferrin decreases with time, and vice versa, the tetrasilotransferrin goes up. So that shows you that glycosylation is considerably improved. You can see the same for another protein. This is AT3. It's a coagulation factor that is better glycosylated. And that's an overview of how we increase the mannose and the disulfiram doses over time. And you can see that there's a considerable effect on the glycosylation of transferrin in this patient, going along with considerable improvement in the clinical condition. The second patient was treated with a combination of mannose and metformin, and in this trial you have a similar effect on glycosylation as well as on the clinical status. So I think in spite of what's the current conception of CDG1A, there's hope that there is a treatment option for these children, and what we would like to do is to have a clinical trial where you treat 10 children for a year or two just with mannose, and the other ones with a combination of either one of the drugs. And I'm trying to find some funding with HUD for that. But just the mannose, just to buy the mannose, although it's a simple sugar for 30 children for 1 year, will already cost close to $300,000. So I will finish with a new disorder, which is also exciting. We discovered it last year, and it already has become a treatable disorder. And the feature of this CDG syndrome is somewhat peculiar. All the patients have a cleft uvula or cleft palate, and all the patients have elevated liver enzymes. They have episodes of hypoglycemia, and quite a few have severe dilative cardiomyopathy, some having been on the list for cardiac transplantation. So the pattern looked a little different from the normal CDG1 pattern. You can see here in these patients you have tetracyclotransferrin, tricyclotransferrin, D, di, mono, and A. So it looked like a type 2 CDG. But when you looked at the immunoprecipitation in SDS page, you see that there's also a complete loss of the glycan with somewhat fuzzy bands here, so there are multiple glycosylation abnormalities. And we used one of these new genomic techniques in order to find the defect in this family. It's a consanguineous family with 2 affected children. And the way that was done was first a homozygosity mapping was done, and I'll show you briefly how that works. So in an ancestor of the child, you have a spontaneous mutation occurring. And then you have recombination in the chromosomes. This person gets children and grandchildren. And from the other the sibling, other genes are transferred, and then generations later, 2 people will meet who have the same mutation, but due to recombinations in the chromosomes, other parts of the chromosome will be quite different. And then you can make the assumption that the gene you're looking for is in a homozygous region, if there is a consanguinity in the family. And then you look for single nucleotide polymorphisms. So 500,000 or 1 million markers distributed all over the chromosome. And you look for regions where the child is homozygous, but the parents or the siblings are not. And if that doesn't work, then you can do whole exome sequencing. And the results were like this. So if we did the homozygosity mapping, we came up with 1,600 genes that could be candidate genes, including one in the galactose metabolism, which was a candidate once. After next generation sequencing and just focusing on these regions where we knew the gene had to be, we came up with more than 200 genes that could be affected. But after all the SNPs were included, there were only 8 genes left. And then we had the advantage that we knew it had to do something with glycosylation. And if you just take glycosylation genes, there were only 2 left. And actually, we favored initially this gluconac transferase here because the other one is a cytosolic enzyme, and never before has a cytosolic enzyme been implicated in CDG disorders. But this turned out to be the wrong one, and this is the right one. So this enzyme is called phosphoglucomutase 1. It converts glucose 1-phosphate that is generated from glycogen degradation to glucose 6-phosphate, and glucose 6-phosphate can then be released to glucose in order to maintain blood sugar homeostasis. And why does this make a hypoglycosylation disorder? So we reasoned that there would be an increase of glucose 1-phosphate, and this increase of glucose 1-phosphate would drive this direction towards galactose 1-phosphate, and vice versa, the UDP galactose pool is decreased, thereby affecting glycosylation, at least the glycosylation in the Golgi, so the type 2 glycosylation abnormalities. So from that reasoning, we developed the concept of maybe if you would increase galactose, either by giving galactose itself or by giving lactose, then you would increase the galactose 1-phosphate pool, and then driving this reaction into the other way, and thereby re-increasing the UDP galactose pool, and thereby improving glycosylation. And when that was tried, either lactose or galactose was applied, you can see that you have a similar effect as I have shown you for CDG1A, that you have an improvement of the normally glycosylated tetrasilotransferrin and a decrease of the hypoglycosylated isoforms. That is not perfect yet, this treatment protocol. We have to work on that in order to make it better. And I don't know yet whether there will be clinical improvements, but at least there's a biochemical effect. As a side effect, because this might well be a treatable disorder and it can have severe problems like a dilative cardiomyopathy, which seems to be reversible. We have looked whether the current neonatal screening test for galactosemia, this Beutler test, can be used in order to find this PGM patients. If you just look at the normal galactosemia screening as it is done in the newborn period, you can see that the PGM1 deficient patients, because PGM1 is involved in the Beutler test, it's one of the enzymes needed for the fluorogenic substrate to be generated, that they are on the lower side, and if you do a modification of it, a slight modification of the Beutler test, you have a clear distinction. So if it turned out to be a treatable disorder, there would also be an option to have a neonatal screening in order to detect the patients before they even get symptoms. So we do what we want to do is research in order to get more healthy children, I have to say. It's not possible, of course, to make the disorders disappear, but I'm pretty confident and pretty encouraged by the past work that we can make quite a significant change concerning the outcome and the quality of life of these patients. Thank you very much for your attention.
We've got time for some questions, and we'll repeat them up here so that everybody knows what's being asked. Crystal?
So great talk. Thank you. Did you have a chance to systematically look at ER stress responses biochemically in these various disorders of glycosylation? These cells have increased ER stress no matter which defect.
Yeah. So the question is, what is about ER stress if you accumulate hypoglycosylated proteins? And of course, you have to assume that if proteins are hypoglycosylated, they will not fold correctly, there will be ER stress induced, and the chaperones will be increased probably in order to prevent the misfolding. That has been done by some groups, but not by us.
Mark?
Just a comment and a question, Thorsten.
Yes.
As you're well aware, there are a number of patients with CDG1A whose transferrin pattern corrects spontaneously. I wondered if you were planning on having a control arm in the study. And secondly, I wondered what clinical outcome measures you were planning to use, because I hate to keep harping about regulatory authorities, but they don't really care about biochemical markers if they can't be linked to an improvement.
Yeah. Yeah, thank you very much for the question. I mean, the first question was, what happens to children if you just leave them spontaneously? And there are reports of spontaneous corrections of glycosylation. These reports are rare. I mean, we have followed many patients for very prolonged periods of time during the initial treatment studies. And they had all very stable amounts of tetracylo and dicylo and acylotransferrin. I only know of 2 exceptions, and one of the exceptions is depicted here, where these are several years of follow-up. It's 1,600 days. And here you can see isoelectric focusing patterns of the patient, where you can see here it's very constant for the first 2 years of life. And then here you have a period of time where you have an improvement of the glycosylation. The tetracylotransferrin goes up, the 83 levels go up for a short period of time, and then it goes back down to the previous state. And we have no idea really why that is. And of course, that has to be controlled for, although I would think it's a rare event. And in terms of what clinical parameters do you want to follow in order to prove that there's a clinical amelioration of the symptoms in this study, I completely agree that this has to be done. And I think we have to discuss it in the CDG community before the study is set up so that we have the right endpoints.
Agreed.
Yes, and you will be included.
Last question, Jeff.
Quick question. So, I thought the lactose at high concentrations is actually
Galnac, or galactosamine, if you give that. Huh?
Well, a baby drinks like 150 milliliter of milk per kilogram body weight and day. If you would do that with 70 kilograms, that would be more than 10 liters of milk you would have to drink. And the galactose content in this milk is coming from the lactose is comparable to what we give here.